and thanks for listening to this fourth update on COVID-19 recorded on the 16th of April 2020. So the topics for this one will be the question about sport and whether 1.5 metres of social distancing is sufficient, a bit about some uncertainties in testing results for COVID-19, the issue of shoes and whether they're relevant to the spread of COVID-19, a bit about COVID-19 and animals, and then the question about why Australia has been relatively spared. So starting off with sports and the question about whether the distance between people doing sporting activities outside is enough. So you might have seen this study from Belgium and the Netherlands, where they did some studies of people running in and cycling in wind tunnels and looked at the question of how far behind them the virus could potentially travel, and came out with the suggestion that you should not be running or riding directly behind someone, and also that potentially for somebody, say, running or riding at quite higher speed, that the distance between people would need to be quite significant, and if you're cycling at more than 30 k's an hour, would even be as much as 20 meters distance separation suggested by their study. And so then the question is, well, is it safe for people to continue doing outdoor exercise in this COVID period? So if we're going to answer this question, first of all, I think just need a quick reminder about the issue of droplet spread versus airborne spread for this kind of infection. So droplet spread being, you can see these droplets coming out of this person coughing or sneezing, and then there's these large ones that you can see, and there's also smaller ones that you can't see. So for droplet spread infections, so things like normal common colds, what happens is these large droplets land on surfaces or land on hands and then get passed to other people from their own hands and then introduced to eyes, nose and mouth that way. Airborne spread is more of a concern here because there's these smaller droplets which you're unable to see, which potentially people could inhale, and that they could go directly into the lining of their airways, such as into their lungs. Now, the droplets that you can see are various sizes. The large ones will fall to the ground pretty quickly, and that's therefore only relevant for the issue of droplet spread. But these smaller ones, which are potentially below the size of 5 millionths of a meter or 5 microns, they're the ones that can potentially be small enough to be inhaled directly into the lungs. So how is COVID spread? What evidence do we have? So if we look at the evidence to suggest that it's nearly all or perhaps all droplet spread, if we look at the experience that we're seeing in the people coming to our screening clinic at the hospital here, just about everybody has a really good story of having had close contact with someone with a COVID infection. We don't see generally anyone with a story of like they just don't know how they could potentially have come into contact with it. Mostly it's people who've had direct contact with others and certainly from close distance. If we look at the situation on aeroplanes, people catching COVID on aeroplanes when there's someone else on the aeroplane coughing, typically that's just within 1 or 2 rows of the person who's got the infection. If it was truly airborne, you'd expect people throughout the whole aeroplane to get infected fairly randomly because of that recirculation of the air throughout an aeroplane. But we just don't see that happening. And then the Chinese studies from their first 75,000 or so people, they looked at this issue and decided that there was really no evidence of airborne spread in their infection. So none of this is particularly compelling evidence, but it all suggests that we know droplet spread is definitely happening, and it's going to be the predominant way that this is spread. There's also a suggestion of just the fact that the R0 for this infection, which is probably somewhere between the range of 2 to 5, is much lower than for a truly airborne infection like measles, where the R0 for measles, the number of cases that one person with it will spread to others in a completely susceptible population. For measles, that's in the range of 14 to 18, so it's a lot higher than it is for COVID. If we look at, well, what is the evidence to suggest that this can be spread by airborne means, so that people are inhaling it directly? So there have been some outbreaks amongst choirs where people singing together have ended up with quite a large number of the choir catching it. Does this mean they inhaled it? It's possible, but it could also mean that the person who was coughing, who had it, was spreading the virus through the air, and that droplets were then landing onto, say, hands or onto songbooks, and so then being passed from those surfaces directly to the eyes, nose and mouth that way. So it could be either. There's certainly been some situations of parties as well, where there's been large numbers of people at parties catching COVID from one person there who had it. And so with these things, we know that when you do talk louder or shout or sing, you're probably exhaling more virus than when you're just talking at a normal volume. So again, it's possible that this is creating some airborne spread. But then again, with the situation at parties, it could be that somebody is breathing it out, coughing it out, and that these droplets are landing on glasses or food or other people's hands and sort of being spread that way through that droplet method. So it's not absolutely clear which it is. For cruise ships, there's certainly obviously some situations of a lot of spread on cruise ships. Is that being spread through the air conditioning system? We don't really know. We don't have evidence to say either way whether that's the case. And the other possibility is that perhaps there is not strict demarcation of the people who've got it from the people who don't. And also, if there are food handlers taking trays of food to the people who are staying in their own rooms, perhaps it's coming in on the food or other shared articles. So it's not clear. There's also the situation of healthcare workers acquiring it, and generally they're going to be in personal protective equipment, and so that maybe that is showing that there is a risk for airborne spread. But again, with healthcare workers, it's generally going to see patients and getting in that very close contact. So certainly within that less than a metre distance where you're going to have droplet spread directly onto your person. So it's unclear what the answer is for this. If we then look at this study which came out a few weeks ago, which was the one that showed that the virus can survive on surfaces like plastic and metal, it also looked at whether they could find the virus in air. And you can see these graphs over here where they could find the virus in air of a patient's room for up to 3 hours. And so that certainly created some interest in this concept that this could be airborne spread, but it's also worth keeping a bit of skepticism and looking at the details of how this study was done. So in this, they had a patient in a room, a closed room, and they gave them a really high-powered nebulizer to make sure that they did generate a lot of aerosols to then see if they could then find the virus in the air. Now, in the 2003 SARS outbreak, we learned the hard way definitely not to give people nebulizers when they have infections like this. And so in SARS, they were able to turn people from kind of normal SARS hosts who are spreading it very rarely to super spreaders, spreading to a lot of people by giving them nebulizers. So we know never to give nebulizers to people with this kind of COVID infection, and certainly not this high-powered turbocharged nebulizer that they used in this study. So on top of that, it was done in a closed room, and so then when they're then testing these air samples, you then can see that there's a gradual deterioration of the amount of virus in the air. And so in this lower part of the graph, you can then see that they've estimated the half-life of the virus is around about 1 hour. So that means if you started off with, say, 1 million copies of the virus floating through the air when you've just done this nebulizer, after one half-life or 1 hour, that will drop down to half that figure of 500,000. You then go another half-life, so another hour, it'll get down to 250,000, and then another hour later, it'll be down to 1/8 And so you can see from that, if you start off with a lot of virus, it'll take a long time to get down to that low level that's below the limit of detection. If you then look at, say, the situation of doing exercise outside, then there's no nebulizer involved. You're also outside. You're not in a closed room. So there's going to be a lot more dispersion of the virus around through that moving air outside. And so that the person also doing the exercise near you is very unlikely to be coughing and sneezing like a person who's symptomatic. They're probably either just before their first symptoms or one of these so-called asymptomatic carriers. And so they're likely to be exhaling a lot less virus than someone who's got symptoms, and definitely a lot less virus than someone who's getting a nebulizer. So if you then think about, right, well, how much virus are they excreting? It's probably more in the range of 100 or 1,000. And if we use the 100 figure, the half-life then, after one half-life, it's going to be down from 100 to 50, and then to 25 after another hour, and then to 12 after another hour. So again, if you start with a lower amount of virus, then it's going to take a lot less time to get rid of that virus as a sort of a viable, potentially contagious source. And that also holds for this study with those surfaces that they talked about with the metal and plastic for 3 days. They did put a lot of virus on those surfaces. So you're then going to be able to find it for a lot longer. And then once again, just remembering from previous talk that this was done with PCR, which is telling you that you're finding the virus's genetic material, its genes, and not necessarily viable virus. And in addition, there have been some other studies more recently where people have gone into the rooms of patients with COVID infection and sampled the air there without giving them any nebulizers, and haven't been able to do it with PCR. They haven't been able to identify any virus in the air. So again, we're not absolutely certain of the answer here. Is it airborne or not? But it certainly looks like the vast majority, if not all of it, is droplet spread, and that this airborne spread is probably just from very close distances and is much less likely. So what do we say for sport? give the recommendation that maintain as much distance as possible for around, keeping your distance from people around you doing sport. And so 1.5 meters, sure, but as much as is practically possible. More is definitely better. And if you are going out running or riding, don't do so directly behind someone, because there is that theoretical risk. Try and keep your distance and move to the side. And if you are overtaking someone else, try and be courteous and do it at a reasonable distance. So don't just kind of bump shoulders with them as you're overtaking them. Give them a bit of space so that you're not getting all that close and causing them the stress of that. And just remember that outside is better. And so certainly with the dispersion of virus outside, it's much better for getting rid of the virus from the air. And so I would still encourage people to do that activity outside and not be too concerned about that study from Belgium and the Netherlands. Now, just as an aside, just on this R0 concept, so just a reminder, this is the number of cases that somebody spreads to when they've got it, and then they go into a susceptible population and how many they're going to spread it to each time. And so initially, we thought with COVID-19 from the early studies that this is in the range of probably 2 to 3, but some more recent studies coming out which have included more of those mildly infected or asymptomatically infected people, that it's probably a higher figure, more like maybe 5. So what's the consequences of this new data? So it does mean a little bit of a change in terms of what we would require for herd immunity to have a kind of protected population. And to achieve herd immunity, you need the number totally immune to be this figure of 1 minus 1 divided by the R0. So if we start off with the example of the R0 being 3, 1 minus the third, then you need roughly 67% of the population to be immune to stop the virus from circulating. If we then say, okay, well, maybe this new figure of 5 is more accurate, then you're going to have to go up to 1 minus a fifth, so 80% infected to have complete herd immunity within a population. And at the moment in Australia, we've had about 0.03% of the nation infected. So we're obviously a very long way away from that. And we're really hoping that a vaccine comes along to get that immunity up to that 80% level. Okay, so moving on to the question about some uncertainties around the testing. So often people think that when you have a test for something like this, that you have a perfect result where somebody who's got the infection here on the left, they'll have a test and it'll be positive. And someone who does not have the infection over here on the right will have a test and it'll be negative. But no test is as perfect as this. What all tests are like are imperfect, where somebody who's got the infection, most of the time they'll test positive, but occasionally they'll have a negative. And so this one would be a true positive, whereas they might occasionally have a false negative. And this person who does not have the infection, most of the time you're going to get a result that's a true negative, but occasionally you'll get this false positive where the test says they're positive, but they don't actually have it. Now, why might you get these? So for the false negative, it might be that maybe when you took the swab from this person who's definitely got COVID, that you didn't put the swab far enough into their nose to detect the virus, or maybe that the swab got something on it that inhibited the PCR reaction and so that it didn't show the virus being present. So there's many reasons why you might get this false negative occasionally occurring. For the false positives here, where it's testing positive if the person does not have it, it might be that there was some similar genetic material in their nose or throat and the PCR detected that as coronavirus, or maybe the sample got contaminated somewhere along the way, or maybe this person's swab got swapped, the labels got misdone, and so that this person's swab got swapped to someone else's who did have it, and that this person's, even though they didn't have COVID, their swab from the other person that did came back as positive. So there's lots of reasons why tests can give you the wrong results. And in fact, it's also worth pointing out that when you do these tests, what your end result in the bit of paper you get at the end of it is the test was positive or test was negative. That's not what the people in the lab see when they're doing it. So they get a reading. And so you can see with this test, so say you've got 500 people there who don't have the condition and then 500 people who do, and you're testing all of them, you get a range of results from this kind of 0 to 100%. And this group on the right-hand side, they're the ones who do have it, and this group on the left-hand side are the ones who don't, and their figures could be anywhere in this range. And so it's not just a positive versus negative cutoff. And so in nearly all tests, there's this kind of general separation, but not a complete separation of the two groups. And so it's possible that you're going to have this little bit of overlap. And when you're developing this test, the manufacturers have to decide, all right, where do we put the cutoff? And they'll arbitrarily put it somewhere around this mid group where the figures below that are negative, and the figures above that are labeled positive. But there's always going to be a bit of overlap, and depending on what you want for the test, what's the key, you might move this cutoff a bit to the left if you don't want to miss anyone, and it's really important to detect everyone who's got it. Or alternatively, if you want to make sure the test is right, so that when you say it's positive, it really is positive, then you might move that cutoff to the right, and so that means you are going to have some occasional false negatives. So it really depends what you want. So what does this mean? Just keep in mind that if somebody does have appropriate symptoms for COVID and everything seems to fit and probably been exposed as well, but the result is negative, then keep in mind that this could occasionally be one of these false negatives. And in this situation, we could potentially repeat the test and maybe then confirm that they do actually have it, or alternatively just say, look, we're going to treat you as if you do have COVID regardless of the test result. We just don't believe that. And then alternatively, if you've got somebody who's got no symptoms and no likely exposure and it comes back positive, keep in mind that whilst it could be an asymptomatic infection, there's also the reasonably strong possibility that this could be a false positive. And down the track, we hope that we've got access to good blood tests to confirm whether people have produced antibodies. That would then be a confirmatory test that you could do to say, all right, is this a true positive or not? At the moment, we don't have that yet. So we're kind of stuck with saying, right, well, if you do have positive, we'll call it true positive, but it might not be. And so we're hearing occasional anecdotes of people who've had zero symptoms at all, had a positive PCR test, and then are not producing many antibodies on the preliminary stage of people doing that. It might be that they never actually had it. It could have been a false positive result. So now moving on to the issue of shoes. So there's recently been a study that's come out looking at hospital floors, where they took swabs of hospital floors to see if they could identify any virus. And going into the rooms of patients with COVID infection and to the wards with these patients, they were able to find it, which is certainly not surprising. If they're coughing, it's going to land on the floors. But they then went to the hospital pharmacy, which was a long way away from these wards, and all the swabs they took from that area also had COVID there as well. So this is certainly a concern that suggests that probably shoes are a vector, that people are walking around in areas where they've got COVID on the floor and then taking it to other parts on their shoes and potentially leaving some virus on the floor. Now, again, this was by PCR, so you're just finding the genetic material of the virus rather than virus that can potentially infect. We'd assume that they are potentially able to infect. But so what do we do about this? I think it's another good idea to leave your shoes outside when you get home, leave them outside. And then also just remember that if you're going to get virus from the floor or from your shoes, it's going to be via your hands. So just that reminder once again to keep your hands clean as much as possible, and particularly before you put your hands anywhere near your food or your face. So then moving on to the issue about animals getting COVID-19 infection. So we have seen some documented infection of animals getting infection from humans. And so we've seen dogs, so a couple of dogs in Hong Kong that were living in small apartments with people who had the infection, and also cats, both domestic, and you probably heard about the tigers in the New York Zoo, as well as ferrets and some primates catching COVID from humans. There's some animals that don't appear to get it, and that's pigs and chickens. So what does this mean? So certainly it looks like we have evidence that animals can catch it from humans, but so far we have no evidence that humans can catch it from animals. But I would still recommend something that I would have recommended even before this COVID era, that don't let animals lick your faces, and wash your hands after handling animals, and particularly anything that might involve animal saliva. So just, it really is going to be related to your hands once again. And then moving on finally to the question of why has Australia been relatively spared, and why we have had relatively low numbers of cases and certainly low numbers of deaths. So there's probably a lot of reasons that are reasonable theories, but we don't know the definite answer. The fact that we're an island nation certainly allows us an easier job of keeping ourselves quarantined, and so that we're then it's much harder to come in that way. Obviously, people have to fly in rather than crossing borders like is the case in Europe. There's probably the issue that we had a delayed introduction here, certainly compared to some of the European nations that got hit very early and very hard. And also the fact that we got probably our first cases relatively later meant that we were able to learn some of the lessons from overseas and try and avoid some of the mistakes that they made early on. I suspect probably the fact that we've got a more spread out population with a lower population density means that maintaining social distance is probably relatively easier than some of the very densely populated parts of the world. It's vaguely possible that some of the strain differences we hear about between different strains of COVID virus, maybe some are more virulent and more aggressive than others, but it doesn't look like that's the case, but maybe there is something to that which we haven't yet determined. Perhaps the lower rates of smoking and vaping in Australia has helped us a little bit, but I don't think that's going to affect transmission of the virus, but it just means that the individual who catches it, if they smoke or vape, they're more likely to get severe infection than someone who does not. So again, if you haven't already done so, please try and get off the smokes and the vapes before you catch COVID infection. Maybe we have lower levels of population in other parts of the world. Maybe that does affect things. Probably not so much spread, but maybe the severity of infection, possible, not really sure. Maybe things like the European greeting of the double or triple kiss brings people's faces in closer contact that maybe facilitates spread, don't know. And maybe the fact that being in the southern hemisphere, getting this starting in weather that's a bit warmer, so our summer period, maybe that has offered some protection as well. But then there are certainly some countries that are relatively warm, like Brazil and Saudi Arabia, that have reasonably high numbers of cases and are certainly quite hot. So I don't think the actual temperature is a huge protector. Maybe it's giving us partial protection, but it's not the whole story. So lots of theories, not clear exactly why, but I think probably we are very lucky to be an island nation and to have that option of quarantining new arrivals to allow it to reduce new cases coming in. And finally, you might have seen this good news story at our hospital. One of the patients was discharged yesterday, aged 94. So it was very exciting to see her being able to be discharged healthy and happy. So that was a great outcome. And also we've got some recent data to suggest that in Australia, the R0, as a result of the social distancing we're doing, is now below 1, which is what we need to eradicate this virus. So it does give us a possible chance of eradication, but certainly there's the ongoing risk of reintroduction from outside, but we're certainly heading in the right direction. So it's very good news to have it so low. So thanks again for listening, and I'll see you in roughly another week. Thank you.